This session is hemorrhagic and blood transfusion.
So, everybody knows about blood reactions, right? Chest pain is an immediate reaction. Your flank pain, your increase in temperature of greater than 1 degree Celsius, decrease in blood pressure greater than 30, right? Everybody knows that. Does anybody know what taco or trolley is? They are blood reactions. They are rare, they can happen, and they're scary when they do. Transfusion-associated circulatory overload is taco. It's like pulmonary edema. It happens immediately. Give them Lasix, pull it off, do fine. Trolley, transfusion-related acute lung injury. That one's the more scarier one. It's like ARDS, their lungs freeze up, you have to vent them. Supportive care, so on, hemodynamics, stuff like that. I've never seen it happen in my career, but we did have someone that came through that did see it happen in theirs. And then these up here are our policies, how you look them up. If you've ever been in our policies, you can't find anything unless you know the keyword. Keyword is blood. And then our order set we have, use it. It's under Gen Blood Transfusion Power Plan, so if you're gonna give blood, use that one. If you're OB, use your the hemorrhage.
We have an OB hemorrhage order set.
Yeah, OB. But this has all your like pre-meds that you would have, your request to blood bank, your order consent, your NS, all the things, so you don't have to order them separately. Fun facts over here, your red blood cells are good for 42 days in the refrigerator and 10 years in the freezer. I feel like they get used more often than 10 years, but. And then your FFP and your cryos 1 year in the freezer, and then 5 days of room temperature for your platelets. Speaking of platelets, our platelets do take a couple hours to get here from the city. So if you're gonna get platelets, it's gonna be a minute. And then our tubings, all of our blood tubing, or all of our blood products go on our blood tubing, except for platelets. Platelets are just ran by gravity. And then your FFP is ran through a filter, but by gravity for our policy. And then our policy does state that the recommended start rate is 100 for when you start blood. I don't know if anybody actually starts it at that fast, but I start about 60, 65. But you can start at 100 for our policy. And then it tells you to go up as patient tolerates. So if you have CHF patient, slower, young kid needs blood, you can probably run it a little faster. This is all routine blood, blood worksheet. Blood worksheet. Every single unit of blood that you give, you fill out a sheet for this. You give a mass transfusion, you give 10 units, you get 10 sheets. Patient sticker, blood number, fill this out completely. Fill out each of the vital signs, and everything that's on this has to match Cerner. Blood bank keeps these for 10 years for audits. And then I get these, I audit these and then hand them back to you. If you do chart it on here and you don't chart it in Cerner, I do have to make you go chart it. If you chart it in Cerner and not on here, I do your solid and write it for you. Unless you keep messing it up, then I will hunt you down. And then, is there anything else with this? I don't think so. Surgery, or what do you guys do?
Pain.
Pain.
ER.
I do that. Yeah. ER, chart your temps, would you? In Cerner? Thanks. It's like, they fill these out perfect and they have all the temperatures on here, but nothing in Cerner, and I'm like, that's weird. Surgery, anesthesia does their own thing. They don't fill out these sheets, they mark it in there, so I'm just gonna let blood bank talk with anesthesia because I'm not sure how all of that works, if it's their own thing, but I do get a report at the end of the month that says all the blood that was checked out from the lab didn't have these sheets, where are they? So then I have to go in Cerner and hunt them down and see who did them, and usually it's a mass transfusion and surgery that we're missing the sheets from, so. Any questions about routine blood? Okay, Connie will do the mass transfusion because she's brilliant at this. That's all OB does. Besides deliver babies.
Okay, so as far as massive transfusion policy, recently the WMMC policy was updated, and it says now we call it overhead. So it would be mass transfusion initiation ICU 4, mass transfusion initiation labor room 4, whatever room the blood needs to be emergently released to, okay? So you call overhead like a rapid response, code blue. Well, blood bank is asking if we still make a courtesy call. The whole reason we're gonna call it overhead is to take away that extra task, because when we're at bedside, you got a lot of things going on when your patient's bleeding, right? But currently, while they're getting everything situated, their ducks in a row and figuring it all out, they asked if we can still have a courtesy call down there. It actually works out well, because when you make the courtesy call, because we have initiated this in our department, called it overhead and I called down, it was wonderful because the blood banks lady said, hey, do you want the platelets on its way? Well, I didn't think about any of that. I was just tasking getting the patient to the operating room. So, you know, I could ask the provider, hey, do you want the platelets? This is 2 hour. Yes, absolutely. So that was good. So that really worked out. So, but if you call it overhead, and if your patient care supervisor or any of your supportive staff wasn't aware that now all of a sudden, you know, your patient's bleeding out, it's a great way for them to know where to go, how to help, and all those things. This is the algorithm that blood bank follows. Okay, so when we initiate a mass transfusion, and when we're saying mass transfusion, not routine, right? Gotta have blood right now. Patient's greatly deteriorating. What the blood bank's gonna do, if you don't already have like any blood down there and hold for that patient who's been cross-matched, right? They're just gonna go ahead and get out O-neg blood, uncrossed, ready to roll, because it's your universal blood. They're gonna get you 2 units of blood. 2 units of blood may come into a cooler like this. It only holds two units. This is the exact cooler, okay? What blood bank will do, they're gonna write the unit number down. They're gonna put what time did they put it in the cooler. Then we need to write down what time we took it out of the cooler. And then if you didn't use both products, what time did you put the O-neg blood back in there or the cross-matched blood? Okay, a lot of times patient care supervisors, they're phenomenal to help us out with this part. Again, because we're tasking. Well, this paper does come with that cooler, but also this emergency release form. This is a mandated form, just like the blood worksheets, blood transfusion worksheets. This form, though, they're going to check mark what products they emergently gave you. Again, they'll write unit numbers and things. But here's the big learning curve that I learned doing all of this prep. It has to have a physician signature. Just a VO order doesn't cut it. It helps on case you didn't get a physician's signature, so the blood bank knows who to track down later to say, hey, we need your signature. I've been doing this 22 years, and I didn't realize I would turn this back into the blood bank. They were still having to go backward and find the doc, get a signature. You're not going to stop your crisis. What we're saying is, the end of your crisis, you've got your patient stabilized. You'll say, hey, doc, before you leave, I need a signature. Okay, so put that in your head. I learned that. So their algorithm, after they get you the 2 units ready to roll, O-neg, they're gonna start thawing out the fresh frozen plasma, solid like a brick of ice. Takes 30 minutes to thaw out. They're gonna get this 8-unit cooler ready. Emergently, they will have 2 units of plasma in there and then 4 units of blood, whether it's still O-neg or if they've had time now to get the blood specimen from the patient to do a tight cross match, okay? Either way, you're gonna get 4 units of red blood cells in here as well, okay? Remember, platelets are on their way if the provider did want them to come. Piece of paper, same thing, unit number, what time it went in the cooler, so on and so forth. This gets filled out, this comes with it too. So every time they do a mass release, more than 1 unit, or emergency release, even if it is 1 unit, they're gonna give you this form, you need a doctor's signature. These coolers do last 4 hours. If you have blood products still in there after 4 hours, it needs to be retested by lab, make sure the temp's okay. More than likely, you're gonna use everything within the 4 hour, or get the patient stable and get the products back. Because remember, any product after it's come out of the cooler needs to be infused within 4 hours. Hence, that's a great cooler to have. These coolers do not go with transport. Do I have any?
ER.
There was a great question brought up, can Lifeline take a cooler with the products during massive trauma? No, they can't. These coolers are very expensive, but if it is a massive trauma, you can let them have the products to hang as they're getting the patient there, but it has to only be lifelike because it's RN. RN is the only one who can initiate it. So if you have ground with no RN transport, they can finish whatever blood may be hanging, they just can't initiate any more bags. So in that case, on your blood worksheet, you would just write on there, this unit sent with life flight with RN, blah, blah, blah. That way, it's legit. They know that the blood just didn't disappear, okay? And so we've talked about that. If you wanna take, you're gonna have to move it over this way, just a little bit. What's that? So massive transfusion kits are being made right now. They haven't hit the facility yet. What's great about this is anytime you're even giving any blood, you gotta hunt down, okay, I need my blood tubing, I need pump tubing, I need my normal saline, everything. Well, you've got 2 pump filters, or blood filters. You've also got like 3 or 4 straight lines, and then you have a couple pump tubings, and then you have your pressure bag if you need to give your blood rapidly. When we give blood rapidly, we're talking 3 minutes, we're talking 5 minutes. In a minute, I will let my friend over there, Miss Ashley, explain what's going on with our mass transfusion machine. But in the meanwhile, also, they have laminated, not only, the algorithm, so you know where you're at in your algorithm for blood bank, but the policy for mass transfusion. So if you're like, how do I do platelets again? All you gotta do is go where it says platelets, it tells you exactly how to run it. You know, no filter, straight line, fast, right? So it's great to have that at hand. Who's got time to be looking at policies and procedures when you're saving a life? I believe in a lot of the units, I'm sure they'll be in trauma rooms. They'll be next to crash carts, operating rooms, those kind of things. So those, be on the lookout, those will be coming.
I don't know about clinics.
FYI, OB department, we always send all of our patients to the operating room with a double line, filtered, hand pump, tubing line. We always have LR going because anesthesia always drops pregnant women's blood pressure. So we gotta keep their blood pressures up with lots of fluid. So if my patient does start bleeding out, I can hang the blood. Yep, LR's still over here, LR's all in here, it's fine. Get your normal saline, replace the LR, it's fine. A little LR with blood isn't gonna hurt the patient. You want the blood in and you want it now. I've heard these are in the trauma rooms in the ER, and we're actually going to investigate and see maybe if this would be proficient to add to the mass transfusion. Because what's great about this, you've got your blood tubing. You have one blood going, normal saline going over here, and you can just run as fast as you can and just keep replacing that one bag of blood, and then you get your hand pump to make it run faster. We still, a lot of times, will stand on a chair, pump this as hard as we can, and push on the bag as fast as we can. So, just so you know, that line may be coming into this bag as well if nobody's ever used it. So, over here we have 2 jugs. I know it's 1.5 gallons, right? The fluid amount in here of blood represents something. Anybody have a guess what this amount of blood represents?
Amount of blood lost and maybe the
Kind of on the right track.
You're on it. It's the amount of blood we have. This is all we carry in our body is 1.5 gallons. In mils, that's amazing, right? Because you look at it and you think, wow, you know, head lacerations look like it loses that much blood. Some women's periods look like it loses that much blood. Either way, so 1.5 gallons is a normal body of blood. Pregnant women have about 2 gallons, placenta and all those great things. So we have a little more leeway with our blood loss. But so if it's 1.5 gallons of blood, how many units is that? How many units do we have in our body? Anybody have a guess? Because you know, unit of blood.
How many mils are
In a gallon.
I know, exactly.
Everybody's
The
like-
nursing's going,
I
okay,
call that 350.
okay, right? So 10 units.
10, good job.
It's exactly 10 units is what we have. So we recently had a hemorrhage and she got more than 10 units of blood. She got all the blood factors. She got the cryo, she got the platelets, she got everything. She's okay, she made it. But just know, she had all her blood replaced. And so her blood typing is gonna change. She's gonna have a ton of antibodies in her blood typing. So it's just amazing to think what the body can do and how we can replace it all. Okay, so standard of care is quantitative blood loss, FYI. Quantitative means measurement, where EBL, estimated, just visualizing. That's not a standard of care anymore, okay? Providers a lot of times will still do EBL, okay? But as nursing, we need to do what is the standard of care, which is a QBL, quantitative, measure it. And so as an exercise to be able to know, you're probably gonna have to move that down, so over here. Oh, I see what you're doing. As an exercise, so an EBL, we're gonna estimate real quick. So there's a left Chuck's pad and a right Chuck's pad. One of those Chuck's pad has this exact amount of blood on there. What would be your guess where this blood is at?
Right side.
Left or right?
What?
It is exactly the right side. I know the right side's a little darker, but it just goes to show, okay, so this is about 130 mils. It's a little diluted out. So that one has this amount. Now, let's do an EBL on this. How much blood is in here? Oh gosh, that was close. 240 is what our orange juices and things are, right? This is 200, but it looks like it would be more than our little orange juice cups that we give our patients. So kind of interesting in that way. So 200 mils is over there. That's another reason why just estimated isn't always great in that case of the patient who lost her thousands of mils of blood. If we would have just estimated, we may have not have proficiently reperfused her. So again, standard care is QBL. I did all that. You want to talk about the mass transfuser?
So, you know, in ER you have your level 1. However, it is on recall, and the blood tubing is on back order. So you don't use it. And then I think that they ordered a Ranger blood transfuser. However, its tubing is also on back order. Hence why you have pressure bags in there. So now it's just manual. Which for most of us, we use manual anyway because we don't have to set it up.
It's easier.
Yeah.
It can be.
Yes.
Yes.
I mean, if we're gonna transfuse like a crap ton of stuff, then
Yep.
obviously we would eventually set that up so we don't have to be squeezing it in. But
So your competency is fun because it's bingo. So instead of sitting in front of HealthStream for hours answering questions, we're gonna play bingo. Here's the rule. Everybody gets a marker, then it's either a straight line or a diagonal. Yell your bingo. But even after somebody bingos, because everybody's got all the answers, they're just in a different order, we have to keep going. We have to do all of the questions, all the answers. That's your competency. So everybody will end up with a blackout, and we do have a prize. And we do it as a great
expect
big
your
team.
inner old ladies to come out in this like you're in a bingo hall. All right. Stop the blood and notify lab of a decrease in blood pressure of what?
30. Oh,
Yep, less or greater than 30 millimeters of mercury.
what do we write? Or do we just fill it in?
Yeah, like, you know, bingo, dab it. A sign and symptom of trolley. You can say it out loud.
Hypotension.
Yeah, good job. Hypotension. When blood has completely infused into the patient, what is that called? It's off this worksheet, but in time.
Yeah.
When blood starts infusing into the patient, what's that called?
Start time.
Start time. Transfusion related acute lung injury. Non-cardiogenic, yes. Trolley. When is the second set of vitals due after the blood has started?
30 minutes.
Yep, 30 minutes from start. The paper that comes with the cooler, you must have what before you give it back to the blood bank?
Toxic.
Yep, doc signature. What is the recommended start rate per WMMC policy?
100.
100 mLs per hour. Vitals you get before you start the blood.
Pre-transfusion.
Pre-transfusion. I'm starting your blood. Please let me know if you have any signs and symptoms of reaction. Chills, flank pain, itching, pain at the IV site. What am I doing? Bottom, middle. Yep, patient education.
Yeah.
Bottom, middle. Bottom, middle. Big letter.
Oh my. Oh my contacts.
I'm having
are
trouble
best
seeing the
ones
big
used.
ones.
Transfusion associated circulatory overload. Taco. Not SS taco, just taco. What must you verify on the patient before giving blood?
Blood band ID.
Blood band ID. When is the last vitals due after the blood has stopped?
1 hour post transfusion.
1 hour post. When is the third set of vitals due after the blood has started?
60.
60 minutes from the start. Pedal edema, pulmonary edema, tachy. Yeah, good job. How long does the RN have to stay with the patient once blood has started?
15 minutes.
First 15.
Bingo.
Woo. Man, you got double bingo. Look at you. Keep going though. Must have
There we go.
this on the chart before you give blood.
Consent.
Consent.
Yeah. Stop blood and notify lab of a temp greater than.
1
Yeah, greater than 1 degree Celsius. Patient sticker that goes at the top middle of the blood worksheet.
Blood body number.
Yep.
Bingo.
Oh,
Good
bingo.
job. Must have this at the top left corner of the blood worksheet.
Patient sticker.
Yep.
Bingo.
Immediate reaction to the blood.
Chest pain.
Yep. Chest
Bingo.
pain. When is the first set of vitals due after the blood has started?
15 minutes.
From the time you pick up the blood from the lab, how long do you have to completely infuse it?
4 hours.
4 hours. How many RNs does it take?
2.
However, LPNs and paramedics can witness your blood with you. They just cannot initiate it. And last but not least, chills, diaphragm size, flank pain. They are signs and symptoms. Everybody get a blackout?
Woo!
Crazy how that works.
She'll pass around the prize bucket. Who got to bingo first?
Me.
Right on.
You got a double bingo.
Yep.
First time.
So he gets to pick his first prize, but
There's
everybody's
these
a
two.
winner, so everybody gets a prize.
Oh.
That's how we roll.
Everybody
It
gets a
made
trophy.
it 2 weeks and it just fell.
Oh no, it's down every morning.
Oh, it is?
Yeah.
Just that one?
Just that one. I keep sticking it back up there.
Where do you get the flashlight?
There's a yellow one. And then, let's see, there's a blue one. A blue? You want a keychain? Or not a keychain, but like a,
Hoopity hoop.
put it on?
I'll just replace my other one. My other one's dying. Or not as far as that, for
I
sure.
don't know what would be helpful for you ladies, but there it is.
This is great for people.
Yes. Well, ICU nurse here, so.
Yeah. Yeah, look at that. Hey, close.
The brightness.
Is it bright?
Compared to.
Dude, people are gonna hate me now.
All right, Connie's got to tell you some interesting facts about preeclampsia.
Hey, ask this red tech if there's any extra in the C-section room drawer. And actually, we could just bring the one from that monitor out and put a note on it that it doesn't have it, since we're always looking into the OR anyway. Does that make sense? Sorry, I'm dealing with a work monitor. Okay. All right, quickly. Preeclampsia, it is hot and heavy on Joint Commission's radar that we need to be educated and ramp up our knowledge of all the warning signs. So the very front of this page is just a quick graph, all the data collected up to 2016, and what it's showing, big pearl of knowledge. First of all, preeclampsia is hypertension in pregnancy or after pregnancy. Lots of people think it's only during pregnancy, but when preeclampsia comes up, it also then, it goes from just hypertension to affecting organs, okay? It affects the liver functions. And if it gets so severe, then it goes to eclampsia, which is seizing. So that being said, 6 weeks is the highest risk that preeclampsia can still happen, 6 weeks after delivery. But women are still dying 365 days later, okay? That was 2016. So we've had COVID, we have coopathy things going on, so it'll be interesting to see what the 2026 figures are gonna show. So if you guys flip over on the back side of the first page, this is a ACOG Joint Commission approved algorithm to follow for any patient pregnant or at least up to 6 weeks, if not more, after delivery. She arrives to an emergency room, urgent care, and OB unit. What we're looking for is in the purple. So 160 over 110 qualifies her as needing to be worked up for preeclampsia, or 140 over 90 with unrelenting like headaches, severe epigastric pain. The epigastric pain's always on the right where your liver is. That's a sign, yep, she's gotta be preeclamptic because her liver enzymes are probably off the chart and it's gonna hurt. It's like a stab that won't go away. It's not like, oh, the baby kicked, or I've got gas, or I've got reflux. It's a true unrelenting, it won't go away, can't catch my breath pain. Then she needs to start getting worked up if she has visual disturbances. And so it says all the lab works and the medications that are appropriate. If her lab work does show, okay, yep, she's preeclamptic, her organs are being affected, she'll have to go on mag sulfate, which is an IV drip. OB, we will take care of that, so she gets admitted, whether she's pregnant or not, back to OB, and we will get her on a drip to keep her from seizing until we can get her blood pressures under control. So if you flip it over, that exact sheet, there's a picture. This is where it's located in the emergency room. There's a laminated copy. It's below the clock above the copier, okay? So that's your quick access. This copy is also located hanging in the doctor's dictation area or little office behind the ER desk, so the providers can also use this as a resource. OB is supposed to, at all times, educate patients, very back sheet, if they have any of these signs and symptoms, which also do include profuse bleeding or hemorrhaging type symptoms. But if they arrive back at an emergency room or urgent care, or they show up outpatient, show up at the office, and they have these signs and symptoms, we have to educate the patients. Make sure you tell them, I just had a baby 2 weeks ago. Because those are the patients that don't sit in triage. They don't sit in the waiting room. They get triaged immediately because we gotta figure out, if she's preeclamptic, she's sitting in the waiting room, she starts to seize, we all lose. And nobody wants a baby not to have their mama. So it can hit home, and I think we're gonna see more and more and more of it. Quick little ditty, there's a nurse that works here in the GI lab, and when we were doing this discussion, she started crying, and she told her story that 10 years ago, her daughter was 2 weeks out after having her baby and showed up in an emergency room. She didn't say which emergency room, doesn't matter. Jessica shows up, doctors, she had all the preeclamptic signs, could not diagnose her, didn't do anything. Long story short, she died. And she allowed, Kathy Dew, she works in our GI lab, she allowed me to share that story. So it can hit close to home. We've been very fortunate here. We've been catching it, they get to OB, we get them on their max sulfate.
How often does it?
Preeclampsia is on the rise. We have more preeclampsia patients than we probably have ever had, and I've been here 22 years. I'm just gonna guess it's COVID related coopathy problems. Of course, you gotta also look at what's our health like, and we have more obesity, we have more, not good food products out there that people choose to eat, and that doesn't help either. So there you go. You guys have all been educated. Now, this sign is being printed as we speak, and it will be at the ER triage desk, so the patients can be aware, urgent care, all those things. So we don't miss it. And I hope you guys have a great rest of your skills day. You guys are done in here. You guys are winners.
Am I still listening
And
for the rest of